So today I have the great honor of introducing you to Dr. Lorna Ross. And Lorna is Head of Department of Design and Creative Media at Atlantic Technological University in Donegal. And she will speak to us about patient-centric healthcare transformation. You are so welcome to the HIT series, Lorna.
Thanks, Patricia. It's great to be here.
It's wonderful to have you, Lorna. And my first question for you today is, Lorna, your career is like a masterclass in interdisciplinarity. And I'm wondering if you could give our audience a glimpse into your journey of how you got there.
I guess trained Patricia in design originally, and I think that kind of ended up in a traditional area of design, which was fashion and textiles, and then kind of going to do graduate work at the Royal College of Art in London, and ending up looking kind of really kind of colliding with very much around what was happening in emerging tech. And so I kind of quickly kind of ended up bringing a traditional design lens into the kind of field of kind of tech research, and that was where I kind of launched my career. And I think I've moved through, as you said, different kind of industry sectors. I worked for the military in the States. I worked in kind of education. I've worked for big tech companies in healthcare. And I think having a design background, you're kind of always thinking about the kind of humanness. I don't know if the word humanity is it, but just the kind of human experience, and I think that probably characteristic of my career has been looking at, systems that are where humans are very vulnerable, and there's a kind of fragility, to the kind of proposition that we're kind of building systems that are pretty, they're optimized for efficiency and for effectiveness, but there's also still this enduring human and spirit kind of story that kind of exists within that system, and the balance, like the kind of equilibrium between how the system is optimized and how much it becomes alien to humans. And so I think I've always looked at systems where humans are particularly vulnerable and become fragile and kind of misunderstood or misrepresented. And so design is about trying to represent and keep really vivid the experience of humans, because I think that, and it is, maybe it's, human-centered design, maybe it's more human-centered innovation, really. It's about kind of really thinking about innovation through the lens of the kind of human experience.
And I'm sure our audience will have so many questions about that, Lorna. But I have another question for you now, and it's really around this innovation and human-centered innovation. And it's you have been called the Florence Nightingale of healthcare design. So what I'm trying to understand is how can design drive real change in healthcare? Big question.
It is a big question. We used to say, when I was at Mayo Clinic, it seems that, again, I mentioned systems a lot. Systems become very opaque and very, people don't, they kind of often don't know how to kind of interrogate them. And so design is, we talked about making the invisible visible. So that was a bit characteristic, was to try and look at what's happening and kind of create representation maps. We often would try and make really vivid experiences, and by doing that people could pause and really kind of start to examine some of the decisions that were being made. So for example, at Mayo, we were doing an awful lot of the journey to digital for the practice, and all this kind of digital health, and being able to kind of and also design is very much about anticipating. So you can simulate. I mean, design is a really, it's a great simulation machine. You can kind of go into the future with design. You can look at multiple possible futures. You can kind of inhabit those futures. You can consider the trade-offs and the effect, and you can kind of look at consequence and adjacencies. And then so it is a real kind of time. I think design is a time travel machine. I think if it's done well, you can actually create future scenarios and then assess the effectiveness and the appropriateness. You can consider, all the tensions that might exist there and the consequences. And I think it helps people make better decisions about the future, because I think otherwise people use historic perspectives, or they use ego, or they use, an agenda to make decisions about the future, or bias. And so I think design is really about, presenting the most vivid way of inhabiting the future. And I think it does really, really inform decision making.
And we'll come back to exactly what that looks like in healthcare. But my last question is, your current role looks at design in the northwest of Ireland.
Mhm.
What you should be teaching students, what skills are missing, and I'm hoping that you'll be able to tell the audience a little bit more about your current role.
Yes. So having worked for like over 30 years as a designer, I kind of, I've a few times thought about when do, education, design education, and I've built big design teams. And so I've looked at from a kind of hiring perspective, the kind of credentials and the skills that designers are kind of turning up with in the workplace. And I think that there's such a kind of disassembly where kind of design is unraveling and it's really needing to kind of rebuild itself. And I think there's a lot of things that are naturally disrupting it, which has happened before. And so it felt like a good time to be in education, really thinking about how to position design in terms of its contribution socially and its contribution, to the environment, its conversation, its contribution to what's happening with government and policy and aspects of that. And then the Northwest, what's really interesting here is there's a really kind of curious experiment around the consolidation across 8 different campuses of ATU is this now the second largest university in Ireland. And it's really new, it's 2 years old and it's trying to bring together all these different smaller colleges. And so I think because there's a bit of a revision and rebuild, it's always an interesting time to come in because, sometimes it's the best time to ask big questions, and so working here to really think about what's happening with design in the Northwest and also with our proximity to the north of Ireland. And there's some, fantastic things happening. We're half an hour from Derry. So that cross-border one island agenda is very, very important. And I think very important to design.
So there's lots of questions. Thank you, Lorna. There's lots of questions coming in from you for you around, and actually someone has asked around your experience of designing combat gear for Navy SEALs. So I don't
Mhm.
know if you want to just give a very quick overview of how did you end up doing that?
Yes. Okay. I very, very quickly how I ended up was I was presenting. I worked in the area of wearable tech coming out of my graduate work and ended up in a lab in Palo Alto. And I presented some work at a conference. And there was also someone at the conference who was presenting on what was happening with DARPA, which is the research agency. And I stalked that person, but they wouldn't talk to me. And so then when I was presenting that afternoon, they came to me and said, I think you should come and work for us. So I did. So I went to work for the Department of Defense research agency, and I worked with them for about 2 years. And just very quickly, I guess the proposition was that they spend, as people probably know, they spend kind of staggering amounts of money in research in terms of developing what was called a future soldier or future warrior, and there was no design in any of these programs. And so I had kind of, I was hired as the kind of design oversight. And so because of this, I had to understand the user community. So I spent 6 months essentially living with a group of Navy SEALs and special operation team in the States, but more just so I could act on their behalf. I could actually kind of, be a proxy voice for the users. They're very atypical. I mean, so there's not something that I intuitively would have understood. So I basically had to break all my own rules in terms of relearning how to represent a very, very kind of, again, unique, atypical, with that they talked about extreme and extraordinary preferences. And so that's something that you can't really assume. So it was fascinating experience. Luckily I was young and naive. So, you kind of, yeah, it was very interesting.
In terms of bringing those skills to healthcare, so how can user experience in healthcare? So who's the user? What does you talked about simulating the future and time travel
Mm.
in healthcare. So how does one do that? How do you do? How did you do that in the Mayo Clinic?
We did, yeah, that's a great question. So I mean, we were very privileged to have so much access. We were, based in the practice. So we were on the floor all the time and we were very embedded in the kind of, again, the clinical practice, and we were commissioned to do work around the patient experience all the time. So we had, extraordinary access into everything that was happening in inpatient and outpatient. And a lot of it was just kind of, trying, really understanding the staff and what they were doing, understanding the tools that they used, understanding the systems that were in place, often to protect people. It's, it's a very regulated industry, understanding a lot of orthodoxies, a lot of things that were invisible, things like an orthodoxy and the culture, like understanding the culture of decision making and hierarchy, and then looking at the patient kind of like colliding into that system and how that, how the patient, how that looks to the patient, and really um, walking in their shoes, but then kind of playing back to the practice. aspects of things that perhaps were not really optimized for the patient, where the patient was really confused, or but the patient was maybe making really ill-informed decisions. And so really optimizing the system back to be very human centric. And so, we were always in the practice, we ran experiments, and we spent all of our time, with patients. We would often have, we would have different designers. They would maybe spend, months with particular patient families in particular as well, because people, Mayo is a destination medical center, so people would often fly either across the country or they'd fly internationally to come. And so getting their backstory and understanding the context of how they ended up there was really important, and also where they wanted to be when they left. I mean, their aspirations in terms of what recovery looked like to them, and the relationship they had with their illness or their disease. I mean, it's very complex how people talk about, their disease or an illness. So just very, very human, very emotional stuff, very kind of sometimes really, really kind of harrowing stories as well. A lot of, so just tough on the designers as well. It took a certain type of designer to be kind of good at that, because you need so much empathy, but you also can't get too invested.
In terms of that, just so you had so many fragmented parts to bring together. I mean, how did you do that? How did design rethink how that care was delivered to that patient?
That's such a great question. We again, I think a little bit what I mentioned about making things invisible. We used to build a lot of maps, and we used to try and kind of layer, kind of understand. We would do lots of diagnostics, so we would kind of think about what are we seeing, what's connected, what's happening, why is it happening. So a lot of it is the kind of forensics of stuff. We would use a lot of patient voice. We would talk a lot about the patient themselves, in terms of how they would feel about things. And then we would do lots of representation. We would try and make a lot of artifacts, and then we would play back stories. And then we would always offer a solution. Like an awful lot of innovation is just, we talk about admiring the problem. So it's just, and this is happening particularly with the environmental kind of narrative right now, is everyone's describing their version of the problem, but no one's coming up with any tangible and, meaningful solutions, but they're great at, admiring the problem. Lots of maps of what's going wrong and lots of charts about how bad it's going to be. And it's just, it's just not helping anything. So we need solutions. And so we would always come with different experiments we believed we wanted to run, and then we would talk about the impact that we would look for in terms of measured outcomes. And so we were quite rigorous and kind of a little bit scientific maybe in the way that we structured the work, basically to prove that what the kind of investment that was being made by the practice was ultimately going to get them the outcomes that they were looking for with the patient.
Okay, great. And that's so interesting. And I'm just so I'm going to bring it back because there's a lot of questions coming in around technology and the future of healthcare and
Mm,
technology and obviously AI, machine learning.
yeah.
So one question here for you is AI game changer or totally overhyped?
um I I think it's probably over. I think it's just really hyped, because, and I think um, I think it's a little bit like, it's the hammer looking for the nail. There's, AI is how we probably felt about, even our smartphones or the web. I mean, I think as technologies, I mean, the kind of technologies are kind of presented as being, there's a lot of kind of techtopia, in terms of really thinking about technology as ultimately always positive, and it's always progressive, and it's always going to solve something. And there is this kind of proposition that if something is developed and we talk about it enough, that there's an inherent value in it. Like, we don't know how to really assess the value. We just know that people are talking about it a lot. I think there's a real difference between the noise, the kind of signal and the noise. Like, what's the signal in the noise? And we know there's a lot of noise about it, but we don't necessarily know how much it's actually changing anything. So, for example, right here in Ireland, we've heard about the 80 server farms and the impact it's going to have on our environment and how controversial it is. And there's this assumption that it's part of a natural process, that we have to embrace the consequence of having AI. We need these server farms, in order to be able to run these huge, kind of, machines. But we don't know what they're doing, so there's no sense of what the kind of payback is. And so I think an awful lot of tech has always been, the investment in terms of the return on investment becomes really, really opaque really quickly. And I think that there's no evidence that there's a significant return on investment that would kind of validate the amount of that what we're investing. I think we should be a lot more cautious. I think also when I was at Mayo, we did all the journey to digital, and what's really interesting is that in healthcare, it's very, very human. And the more you try and standardize things and the more you try and automate things, the more you try and kind of like, kind of outsource stuff to this happens in mental health a lot, is trying to outsource the most complex area of medicine to an app and asking people to go home and do use a meditative app for their mental health. You're really tech washing aspects of healthcare that are so completely complex. And what's so hard is that there's people are looking for a systems level solution to an individual level problem. So they're looking to find a kind of systemic solution that will be a fix for everything, to an aspect of medicine that is very individualized. And so I think there's always a role for tech inside systems. I think right now I would say AI and the kind of the kind of brands behind them are probably trying to sell it into the wrong parts of medicine. They're probably trying to put it too far up the food chain, and the narrative is too much that it's going to be replacing kind of human intelligence. I think there's always a use for, I mean, it's the difference between a servant tool and a comrade tool. I think there's always a use for these tools. But I think that we don't, you can, unless you can standardize that part of medicine safely, then you can't give it to tech.
So there's some lovely comments coming in. We're actually completely running out of time, and there's some lovely comments coming into you. One from Michelle Burns, who said it's amazing to have your skills in ATU. So that's a really nice compliment. And
Oh.
I just want to wrap up because we are running out of time. So I want to wrap up and just, you said earlier, you looked into the future, so you've seen the future, Lorna. So I suppose what makes you excited, and what's the greatest opportunities for innovation in healthcare that you can see in probably 60 seconds?
Oh my God. I would say that it is, I'd love to see the healthcare conversation and the kind of environment conversation become the same conversation. I think there's a lot about the kind of the fact that, what is kind of our what is natural about the human and what makes us part of nature. Is is as much our vulnerability, but it's also our resilience and our strength, and how much we are kind of shaped by patterns, and we are shaped by generations, and we are shaped by our by nature. And I think understanding the kind of natural aspects of how what makes humans thrive, and understanding the aspects of what helps nature thrive are the same thing. And I feel like that we always kind of parse all these conversations and we fund them differently, and different people with different expertise go into separate rooms to have conversations. And and it just feels like there's a kind of meta conversation around that aspect of kind of us as part of nature being healthy and resilient and thriving and finding balance. And I think that if we found balance in many aspects, then our health would be less of a conundrum. We'd be less confused by I don't know why we are so confused about what keeps us healthy. I mean, we know what keeps us healthy. It's the same things that keeps the planet healthy.
I'm going to just stop right there. That was just phenomenal. Thank you so much, Lorna. Absolutely. And unfortunately, we are completely out of time. So sincere apologies to all of you whose questions I did not get to, but I want to take this opportunity to say a huge, huge thank you to Lorna. Thank you so much.
Thanks, Patricia. It was so lovely. And yeah, it was just nice to connect here. And thank you for the invite. I'm really privileged to be here.
It was incredible. And thanks. I love the fact that you said human about 25 times, because
Yes,
our first word in this
always.
series is human. And so I think we've, human and just bringing disciplines together. And it's all about, for me, interdisciplinarity. I just thank you so much. It was incredible to have you on. And look, for everybody who's listening, please do check out our website for our upcoming list of speakers. And we're also on Spotify, and we're also where you get your podcasts. So please do keep in touch, and see you all very soon on our next UCD HIT Series.